All right. Okay. Good morning, everyone. So thank you, Amila and the council for inviting me to give this talk. So the topic that I was given is retinal emergency. So I was assuming, am I going to talk only about the retina, or am I going to talk a little bit about the posterior segment as well? Because when I had a look at the agenda and the list of talks, I thought it's better for me to talk a bit more about the posterior segment as a whole, rather than just talk about the retina itself, right? So I'm going to be talking a bit about the posterior segment issues that will present to you guys, right? The optometrists and the nurses that may be managing patients, and the people who will be seeing the patients for the first time, and the things that you need to be looking out for. So I'm going to be talking a little bit about, just to refresh your memory about the anatomy and the physiology of the posterior segment, the retina, and the signs and symptoms that retinal diseases and posterior segment diseases will present, how these things will present. And we'll talk a few issues related to these emergencies. So posterior segment issues related to the lens, the optic nerve, the retina vasculature, and the retina and the vitreous per se. So these are the things that I'll be talking about. Now you remember the eyeball, we have learned this from grade 5, the 3 layers of the eye, the outer fibrous layer, the middle vascular layer, and the inner neural layer, which is the neurosensory retina, and the lens is in the middle, dividing the eye into the anterior segment and the posterior segment. So the posterior segment is filled up with the vitreous. So my talk is going to be based on the things at the back of the eye, the retina and the vitreous. So if you look at the inside of the eye, you will remember that you have the fundus appearance. So I'm sure most of you optometrists are senior, and there may be trainees as well, but in your course and your education also, that you are taught to look at the fundus, use your direct ophthalmoscope, and if you are trained enough, you can use the slit lamp to look at the fundus as well, and this is what you will see. So you have the optic disc where the neurosensory fibers exit the retina, and then you have the central macular region with the fovea, which is the most sensitive area of the eye, and then you have the vasculature, which forms 4 arcades: the superotemporal, superonasal, inferotemporal, and inferonasal. So if you take a cross section of the retina itself, now we are taught that the retina contains 10 layers, and this is actually an extension of the brain itself. So it's not just a simple peripheral nerve or a simple sensory organ. It's actually an extension of the brain itself, and then that's why there is a lot of neural processing that goes on in the retina itself. So that is why if you have any form of damage to the retina, the retinal damage is usually permanent. It's just like having a stroke, right? If you have a blood clot going into the brain and that part is dead, it's very difficult, or it's practically impossible to get that part recovered. Similarly, if you have a problem in the retina, any area in the retina, if that gets affected, then that damage is usually irreversible if not corrected in time. So that's why the retinal pathologies need to be treated, and attention has to be given promptly, quickly. So that's why this emergency issue is there. That's why this talk is there, so that you have an idea which conditions that need to be referred quickly. So these are the retinal layers. I'm not going to go into detail. Just a little bit about the physiology of the eye as well. Remember, the things that you see outside are going to be forming an image which is inverted upside down on the retina, and then the visual pathway is going to take that information back to the brain, and at the brain only you form the image and you identify the structure. So having a healthy eyeball itself is not good enough for someone to see. That is the point that I am making here. You can have a very healthy eyeball, but the path to the brain has to be good. At the same time, the brain needs to be functioning as well. This is a bit of an idea of how we get the three-dimensional vision. Okay. So now moving on to the symptoms, these are the things that the patient will come and talk to you about. So when it comes to retinal symptoms, these are the things that you need to be aware of. Poor vision, blurred vision. So when you get a patient with blurred vision, that is the commonest complaint that the patients will have. You have to get an idea, you have to ask, is this acute or not? Is this a recent onset blurred vision, or have you had this vision gradually getting worse? If it's an acute onset blurred vision, chances are that this may involve the posterior segment. Then scotomas. What does scotoma means? That means patches of the visual field getting blurred. So sometimes if the patient is very observant, they may say, look, doctor, me patta me hariya penne mage, me hariya vitarai. Anik hariya peenawa. Naththam meda mata penne wate peenawa. So those are kind of like scotomas. So that means part of the visual field or a patch of the visual field is having a blurring. So this is another symptom that may indicate something is wrong in the back of the eye, posterior segment. Photopsia. Photopsia means, certain changes in part of the visual field. It can be like flashes of light or like shimmering, or dilisena wage, gahena wage. Different patients are also finding it sometimes difficult to explain, but it will be, you have to kind of ask specific questions and get this information. So it can be eliyak yanawa wage dakka, nikan dilisenawa wage dakka, or dati yanawa, nikan akunu gahanawa wage. Those are the explanations that the patient will give. Those are also indicators that something in the back of the eye is going wrong. Then floaters. Floaters kiyanne ara kali peen එක. This we all have. Most of us, if you look at a white background or look at the sky, sometimes you will see a small particle. And you can follow these and they move all around. So those are the floaters. All of us, if you look closely, you will have. But acute onset floaters means that something is happening at the moment. So floaters of acute onset are important. Then a painful red eye. Sometimes a painful red eye may indicate an anterior segment problem, but if something wrong is going on at the posterior segment, that may indicate a posterior segment issue as well. So particularly a red eye with a vision loss may indicate a posterior segment problem. So these are the symptoms. Symptoms kiyanne patient avilla oyata kiyana de. Symptoms that a patient will come to you, and then that may indicate that a posterior segment or pitipasse when a problem again. Then you have to know a little bit about the signs. Signs kiyanne api elicit karana de. What do we get from the patient? So palaveni de tamai, first thing is visual acuity. Obviously you have to check the patient's visual acuity and check, if possible, the visual field. You don't need to have a Humphrey's visual field to assess the visual field. Sometimes you can, close one eye and compare yourself with the other person. It can confrontational field assessment. You sit in front of the patient, you ask the patient to cover one eye, you cover one eye and check, are you seeing this area? Are you seeing this area? So sometimes the vision may be normal, 6/6, 6/9 vision, but the field may be having a loss. So then you will be able to catch a scotoma, the area of the field having a loss. So that is something simple that you can do in your practice, in your shop itself. So you don't need to have big gadgets of visual field analyzers to assess the visual field. It's easily can be done at the bedside. Another thing that you need to learn is to check the pupillary reaction. Now we always usually jump into checking the fundus. If something is wrong, poor vision, we dilate the pupil and immediately try to look at the inside of the eye. But if you look at the pupillary reflex, that gives you a lot of information about the posterior segment of the eye, the nerve and the retina. So this pupillary reflex checking, it's a little difficult to explain at the moment, so I'm going to just run this video. And you need to, hope it's playing, yeah. So I hope the people at least at the front can see. We shine a torch onto one eye, patient ke left eye ka balanna. Patient, if you look at the patient's left eye, the pupil constricts. But when you shine the torch to the patient's right eye, the pupil dilates. Penwada manda. Pupil dilates. So what does that indicate? Usually if you shine a light to one eye, then the pupil should constrict. Anik pattata karat et constrict when known. But here the pupil dilates while shining the light onto that same eye. So that indicates that the nerve in the right eye is not carrying enough information to the brain. That is the simple explanation. And so this indicates, this pupillary reflex, it's called a relative afferent pupillary reflex or a afferent pupillary reflex. This indicates that a posterior segment problem is going on. And it's a simple test that you can do in your practice to differentiate whether the patient is having a posterior segment issue, that means either a retinal or a nerve issue, optic nerve issue. So simple things that you can do to differentiate things there. Right, so with that information, now we'll look at some of the things that you will come across as retinal emergencies. So I'm going to go according to what I described to you earlier. So what are the lens-related retinal emergencies? Now, usually, lens will be located nicely in the center and the pupil will be visible there. But if you have had the lens dislocating, either the crystalline lens that you are born with or an implanted lens, this may present to you as an acute emergency. So what are the symptoms that the patient can have? And the lens, it can be in the pupillary plane, or if it's dislocated completely, that this is like a sublux lens, part of the lens is in the visual axis, or it can be completely dropped into the back of the eye. So an implanted lens, this is the lens lying on the retina, right? So then how does these things happen? Well, it can be because of trauma. It can be because of trauma. Obviously, blunt trauma can sublux or dislocate the lens very easily. It can be following surgery. Sometimes surgery can be could have had met with a complication. So the lens could have been, or the IOL that is put in could be subluxed. Sometimes the lens is in the correct place after the surgery, but after about maybe a few weeks later, the lens may dislocate into a different position. So all these things are causes of an acute drop in the vision. Obviously, the lens, if the lens is there, it's fine. If it gets subluxed or dislocated, there will be a patient will explain to you that there is a sudden drop in the vision. So what are the other causes? There are other conditions where the lens zonules. Now you are familiar with the lens zonules. The lens is held by the ciliary body with a large number of zonules. So if there's a weakness in zonules due to various conditions such as Marfan syndrome, there are other conditions like homocystinuria, or the commonest condition that we are familiar with as eye surgeons and you optometrists is a condition called pseudoexfoliation. So if you have had a look at the eye through a slit lamp or even with a torch, you may be appreciating the patient having these small white dots on the lens. So these are patients who are having pseudoexfoliation. These patients have weak zonules. So on their own, they can have a dislocation of the lens, or following surgery or during surgery, they can have a complication where the lens can drop in. So if the lens drops into the back of the eye, then it's a retinal surgeon's issue that needs to be sorted out. So these are things that the patients will come to you with. So a sublux lens, patient will come to you with two complaints. One, there may be a sudden drop in the vision, where the vision is lost if the patient completely loses the lens, or they might even complain of a condition called what we call monocular diplopia. You know, diplopia is when you have both eyes working together, but the two eyes are seeing two different images. Double vision. Diplopia is double vision. So usually, if one eye is turned one way due to either a neurological problem or a muscular problem, then the two images that the two cameras are getting are different. So the brain interprets as two images and double vision. But usually when you have the two eyes working on side by side, if you cover one eye, the double vision disappears, right? But monocular diplopia means that with a single eye, two different images are going into the brain. So if you have a sublux lens like this, you can imagine this part of the light going through this part of the lens is focusing at a different object, and this part of the lens, this part of the pupil is getting a different object. So even when you cover one eye, the patient will be complaining, I am seeing two different images and two different blurred images. So monocular diplopia and acute blurred vision are indicators that something is wrong. You can even shine a torch and get this information, or look at the patient through a slit lamp and get more information. Then I'm going to talk a little bit about optic nerve related pathologies. Now these are conditions at the back of the eye. These are serious conditions which affect the patient's vision. Usually optic neuritis or other optic neuropathies are conditions where the optic nerve has some form of inflammation or swelling. So these patients usually do not have a significant pain description. Sometimes they may complain of pain on movement of the eyeball, but these are usually very dull pains, not very significant pains. The main complaint that they will have is the significant drop in the vision or a large area of scotoma. So compared to the whole retina, you can imagine this optic nerve is a small area. It's about 1.5 millimeters. The optic nerve diameter is about 1.5 millimeters. So something significant can happen which can drop the vision very drastically, right? So sudden drop in vision and usually painless or a scotoma, these patients, you have to check the patient's vision, and the classical thing that most of these patients will have is the thing that I described earlier, the afferent pupillary defect. So optic nerve pathologies usually will have an afferent pupillary defect. So if you check the pupils with your torch, you will be able to catch that poorly reacting pupil. So that will indicate to you something serious is going on. We need to either refer, or if you have the facilities to look at the fundus, if you look at the fundus, you will be able to see that the optic nerve, the normal optic nerve that has the nice edge, that edge is now going to be blurred. So the edge is going to be blurred, and this is a swollen disc, right? So you can see that the nice edge here, seen here, is not there. So it may be swollen, there may be hemorrhages at the disc, right? And the optic disc, optic cup is going to be obscured, and it may appear like a smaller cup. Or some of these pathologies are completely they will not have any signs whatsoever. That means they may not be showing any pathology in the optic nerve head. That may be because the pathology is happening a little beyond the disc. Okay, so these patients, sometimes these neuropathies are described as where the patient can't see anything, the doctor can't see anything, right? Because the patient is also having a poor vision, but the doctor is also not detecting any problem. But obviously there is a problem. The problem is beyond the optic disc, right? So whatever that whatever you can find, if you look through at the fundus, you have to describe, and these patients, obviously, they need to be referred urgently so that we can make a diagnosis and start the treatment. So optic nerve related issues are important for you to detect, and don't forget the pupillary reflex. Then we will go on to the retinal vasculature. Now, I told you the retina has 4 arcades, 4 vascular arcades. So you have the arteries which are draining giving the blood to the retina, and then you have the veins that drain the blood out. Right? So those are the retinal vasculature. You also have a choroidal vasculature, which we are not going to discuss today. The retinal vasculature, obviously you can imagine the arteries can have a problem or the veins can have a problem. So when the arteries have a problem, that is not a good thing to have. These patients will present to you with sudden onset painless vision. So eye is having no pain whatsoever, eye is not red, no inflammation, but a sudden acute drop in the vision. And usually if the central retinal artery is affected, like in this case, the visual drop is very significant. Okay? And you can check the patient's visual acuity, you can check for the pupillary reflex, and if you have a good look at the posterior segment, you will be able to see that the retina does not have this nice orange color, and the retina is going to look very pale, whitish. Sudu paata vela, sudu nelu vela wage thamai retina එක පේන්නේ. And if you look closely enough, the arteries are all very narrow and very thin, attenuated කියන්නේ ඒක. හීනි වෙලා නැති වෙලා ගිහිල්ලා. So the whole retina looks very pale, but because the retina is very thin at the macula, at the fovea, the choroidal blood will appear red at the center. So this is what we call a cherry red spot එකක් කියලා. Cherry red spot කියන්නේ cherry red cherry එකක් වගේ. රතු පාට එකක් පේනවා, වටේම සුදුයි, මැද හොඳට රතු පාට dot එකක් වගේ පේනවා macula එක. So that indicates that the retina is not getting enough blood. Whole retina is ischemic, and this can be because of one of the main central retinal arteries getting blocked. So there are different reasons for those things. I will not go into that because of time, but this is something that you need to refer the patient as soon as possible. But unfortunately, just like a stroke, now we talked about the retina being like the part of the brain. So just like a stroke, if the blood clot is not removed or dissolved within about 4 or 5 hours, the damage is irreversible. Right? Damage is irreversible. So it's very difficult for a patient to come within that time, and it's very difficult for us to try to dissolve the blood clot also within that 4 to 6 hour time period. So patients who are coming with these pathologies are usually not going to have a very good prognosis. The other slide is showing one of the branch retinal arteries having a block. So this can be due to cholesterol plaque, can be due to hypertension, high blood pressure, can be due to other systemic conditions where the blood vessels get blocked. So this patient is having a inferotemporal branch retinal artery occlusion. You can see the pale retina, සුදු මැලි වෙච්ච retina එකක්, but the rest of the retina looks okay. So if the central retina is okay, if it is getting enough blood, you may have the patient having adequate vision, but this patient obviously is going to end up with what? If the inferior temporal retina is going to be completely ischemic and it's going to not be functioning, the patient is going to have a supraronasal scotoma. කළු එක පැත්තක් ඒ field එකේ visual field එකේ loss එකක් අනිවාර්යෙන් එනවා. Okay? So these are conditions that need to be immediately addressed, because if one eye is affected with a blood clot, what does that mean? The patient is prone to have blood clots. The patient, if one blood vessel is getting a clot, then the rest of the body is at risk of blood clots. The next blood clot will be in the brain. the next blood clot may be in the other eye. Okay, so that's why these patients need treatment. Even though we might not be able to save this eye, we have to treat the patient so that future episodes don't happen. So this is the arterial occlusion. When the artery is blocked. What happens when the nerve is blocked? When the veins are blocked? When the veins are blocked, because the arteries are pumping blood, the capillaries are going to leak blood out into the retinal neurosensory retina, and you are going to have lots of hemorrhages all around. Lots of hemorrhages. So the disc is going to be swollen, all hemorrhages all around. Now this is a central retinal vein occlusion. The main central vein has got occluded, so you are going to have blood all over the retina. Sometimes one of the branches can get occluded, and then only one quadrant of the retina can get blocked, can get affected. So all these things are related to which part of the vessel is blocked. So these patients may also sometimes come to you with acute vision loss or a scotoma, part of the visual field is gone. But sometimes these patients may be asymptomatic. Why? If the patient is not very observant about the visual field, and if the central retina is not affected, central macular area is not affected, the patient may have reasonable vision, 6/9, 6/12 vision. Okay? So it's your job to check the fields, and you may be able to detect something if you look at the inside of the eye, because this is very obvious, very easy to detect. The vein occlusions are very easy to detect. If the central retina is getting affected, then the macula will be swollen, and then these patients will have an obvious drop in the vision. These patients will obviously come to you, and if you have the facilities, and if you may not be able to appreciate the macular edema sometimes, but if you do a OCT scan, easily you can detect the macular edema associated with vein occlusions. So these are things that you need to be able to detect, patients coming acutely and suddenly presenting. Finally, let's talk about the retina and the vitreous problems. The most important things and the commonest things that you will come across. Now, as we grow older, the vitreous, which was where we were born as a gel, now kind of liquefies and dissolves and kind of breaks down into small pieces and collapses on itself. So when this happens, what happens? The vitreous may form small particles. So the patient may start seeing these particles as what? Floaters. If the vitreous is attached to a retinal area of the retina, and that has a small pull, attraction, then the photoreceptors will get stimulated, and you will start seeing a small flash as well. So most of these small flashes or these floaters are benign, and they are associated with a posterior vitreous detachment. But it can lead to more problematic causes where the patient can have a retinal tear. And it's very difficult for you to differentiate what is a benign or a harmless floater compared to a dangerous floater. The important thing is the onset of the symptoms. If the symptoms are presenting acutely, there may be a dynamic or a active traction happening, and then these patients need to have a thorough examination of the peripheral retina, right? Not just dilated and the central retina. You have to have a thorough examination of the peripheral retina, because sometimes these vitreous, in a patient, the vitreous may be attached to certain weak areas, like what we call these lattice degenerations and these various other snail track degenerations. So peripheral retinal degenerations are associated with the vitreous having a more tighter connection. So when the posterior vitreous detachment happens, or the PVD happens, when the vitreous comes off, there is a higher risk that the retina can end up with a tear like this, a retinal tear. So when a retinal tear happens, again the symptoms will be the same. A peripheral retina will the patient will have a few floaters coming across and the flashing lights where the photoreceptors get stimulated. So these patients, acute onset for patients, you need to make sure that these patients are referred to an eye surgeon as soon as possible, because acute onset photopsia and floaters need to be treated as soon as possible. And if the patient is detected early enough, we will be able to do the laser, try to seal the tear and, get away with it. Because if the patient doesn't present soon enough, what happens is, through the retinal tear, fluid is going to go under the retina and slowly the retina is going to detach, right? So if the patient doesn't present to us acutely, if the patient doesn't come, then as the retina slowly detaches, the patient will start seeing like a curtain coming across his visual field. It may be from the top, it may be from the bottom, so it's a gradually worsening scotoma. And when the central retina is affected, the patient will have a sudden, significant loss of vision. So if a patient complains to you of floaters, acute onset, flashes, acute onset, or some kind of a curtain coming down or a scotoma, you need to get these patients referred. I'm running over time by about a minute, so I'm going to rush through. One other thing that you need to be aware of is vitreous hemorrhages. Vitreous hemorrhages will present to you with a sudden acute vision loss. They may be associated with floaters. There are so many causes of vitreous hemorrhages, and it's very difficult to describe all these things. Could be vascular problems, traumatic problems, could be age-related issues. But if you look at the fundus, you will be able to detect various forms of vitreous hemorrhages. If you have a patient with a vitreous, obviously you need to refer the patient to identify the cause, and we may be able to treat. Okay, so coming to the end of the talk, it's important that you refer patients of acute onset vision loss, photopsia, and floaters to an eye surgeon as soon as possible. It's very good to learn the art of interpreting the pupillary reflex, an afferent pupillary reflex or a relative afferent pupillary reflex. It's very nice, and if you detect it, it gives you a lot of very good information. You have to be aware of the retinal emergencies or posterior segment emergencies that I talked about, and it's very important that you learn to look at the fundus. Not only for retinal pathologies, just like the speaker before, he was describing about the glaucoma and the optic nerve, asymptomatic diseases, a lot of asymptomatic diseases can be detected if you just use the ophthalmoscope or your slit lamp to look at the posterior segment. Right, thank you.